Bismillahirrahmanirrahim. Quote of the day. When proven wrong, the wise man will correct himself, and ignorant will keep arguing. By Hazrat Ali bin Abi Talib. I'm Dr. Muneeb, and today my topic of presentation is anemia under supervision of Professor Dr. Saira Afzal. So, what is anemia? Anemia is and without emia blood is the decrease in hemoglobin, hematocrit, and number of RBCs count, resulting in lower ability for the blood to carry oxygen to the blood tissues. According to WHO, anemia is a serious global public health problem that particularly affects young children and pregnant women. WHO estimates that 42% of the children less than 5 years of age and 40% of the pregnant women worldwide are anemic. Now, the pathophysiology. The decrease in RBCs, hematocrit, or HB level causes the decreased oxygen carrying capacity of the hemoglobin, which leads to hypoxia, and hypoxia induced effects on the organ functions, leading to the signs and symptoms of the anemia in the patients. Normal values. Normal values of the HB in the adult man is more than 13 gram per deciliter. In the woman, it's more than 12 gram per deciliter. In the pregnant woman, it's 11 more than 11.11 gram per deciliter. In the infants from the age of 2 to 6 months, it's more than 9.5 gram per deciliter. In the children from 6 months to 24 months, more than 10.5 gram per deciliter. In the 2 years to 11 years old, more than 11.5 gram per deciliter, and in the children from the 12 year, it's more than 12 gram per deciliter. Now, the classification of anemia can be done on the basis of morphology or on the basis of cause. On the morphology, it's normocytic, microcytic, or macrocytic, and on the basis of cause, it will be the blood loss or inadequate production of normal blood cell or excessive destruction of the blood cells. Types of anemia. So the clinically it has anemia has following types: the iron deficiency anemia, megaloblastic anemia, hemorrhagic anemia, pernicious anemia, aplastic anemia, and hemolytic anemia, which includes thalassemia or the sickle cell anemia. Now we will have the brief description of all these anemias. In the iron deficiency anemia, excess loss of iron or less intake of iron. Women are at the risk for the menstrual bleed and growing fetus in the pregnant women. In the megaloblastic anemia, less intake of vitamin B12 and folic acid or red bone marrow produces abnormal RBCs due to some cancer drug. Pernicious anemia, inability of stomach to produce the intrinsic factor which absorb vitamin B12 in the small intestine. In hemorrhagic anemia, excessive loss of RBCs through bleeding, such as the stomach ulcer, menstruation, or any kind of accidental trauma. Hemolytic anemia, RBC plasma membrane rupture, which causes the bleeding leading to anemia, and may be due to any parasite, toxin, and antibiotics. Thalassemia, less synthesis of hemoglobin, more presentation occurs in the Mediterranean Sea population. Sickle cell anemia, hereditary blood disorder characterized by RBCs that assume an abnormal and sickle shape. Aplastic anemia, there is a destruction of red bone marrow that can be caused by toxin or the gamma radiations. So now morphologically, if we see the normocytic and normochromic anemia, in these anemia, the MCHC and MCV remains the normal. These include the anemia of chronic disease, hemolytic anemia, anemia of acute hemorrhage, and aplastic anemia. The second is hypochromic microcytic anemia. In this anemias, there will be low MCHC and low MCV, and they include iron deficiency anemia, thalassemia, and anemia of chronic disease. Now, the normocytic macrocytic normochromic anemia. In this anemia, the MCHC will be the normal, but MCV will be high. So these include the vitamin B12 deficiency anemia and the folate deficiency anemia. Risk factor: poor socioeconomic class, multiparity, teen pregnancy, and menstrual problems. So these are the other risk factor. The dietary factor, social factor, and the demographic factor. And the dietary factor, there is a low vitamin C intake, excess phytate intake, excess intake of tea and coffee, low iron or heme iron. In the social factor, alcohol abuse, depression, GI disease, or poverty. And in the demographic factor, female, adult depression, teenager, immigrants. So, if all of these three factors are present in an individual, it will put that individual at a very high risk to having anemia. Now, these are the risk factors which are occurring in the iron deficiency anemia. So, for pregnancy contributes 43% of having the iron deficiency anemia. Then, nutritional inadequacy is 15%, whereas gastrointestinal pathology are 15%, menorrhagia is 9%, hemorrhoids are 8%, hookworms are 8%, hematuria are 2%. These are the risk factors which affects the iron deficiency anemia. Now the causes of anemia: increased requirement uh, and increased loss, decrease intake, and decrease absorption of the iron. So increase requirement, it's actually happens in the menstruating female, in the pregnancy, in the lactation, or the growing infants and children, or the erythropoietin treatment. And increased loss occur in the GI, bleeding or menorrhagia or persistent hematuria or intravascular hemolytic anemia or regular blood donor or the parasite infection. And decreased intake occurs in the vegetarian diet or the socioeconomic factor. Decreased absorption occur in the upper GI pathology like celiac disease or Crohn disease, and gastrectomy and medication like NSAIDs and Zantac causes the decreased absorption of the iron, which leads to the anemia. Now, the common symptoms of anemia are the early fatigue, loss of energy, usually rapid heartbeat, particularly with exercise, and shortness of breath and headache, particularly with exercise, difficulty in concentration, dizziness, pale skin, leg cramps, insomnia. Signs on the examination: the doctor will see the koilonychia, angular stomatitis, brittle hair, atrophy of the papilla of the tongue, and dysphagia and glossitis, Plummer-Vinson syndrome, or the brittle nails. So in this picture, we can see that different systems are affected by the anemia. Firstly, starting from the central system, fatigue and dizziness, and in severe cases, fainting. In the blood vessel, there will be low blood pressure. In the heart, there will be palpitation, rapid heart rate. But in severe cases, it can lead to the chest pain, angina, or heart attack. And in the spleen, there will be spleen enlargement. In the eyes, there will be yellowness. In the skin, there will be pale, cold, and yellow. The respiratory system, there will be shortness of breath. In the muscular system, there will be weakness of the muscle. And in the intestinal system, there will be the changed stool color. Now, investigation for the anemia. Red blood cell population is defined by quantitative parameters and qualitative parameters. Quantitative parameters are the volume of bag cell, the hematocrit, and hemoglobin concentration or red cell concentration per unit volume. And qualitative parameters are mean corpuscular volume, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentration. Hematocrit, bag cell volume. It is a proportion of volume of blood sample that is occupied by the RBC. In men, normally it's 42 to 53, 52%. In the female, it's 36 to 48%. Red cell count, the total number of red cell per unit volume of the blood sample. In the men, it's 4.2 to 5.4 into 10 raised to power 6 per millimeter cube. In the woman, it's 3.6 to 5.0 into 10 raised to power 6 per millimeter cube. And the cell volume hemoglobin concentration, it is the amount of hemoglobin per unit volume of blood. In the woman, it's 12 to 16 gram per deciliter. In the man, it's 14 to 17 gram per deciliter. Labs. In the mean corpuscular volume, it is the average volume of the RBCs. Normal range is 80 to 100. And mean corpuscular hemoglobin, it is the average hemoglobin content per RBC. Normal is 27 to 31. Mean corpuscular hemoglobin concentration, it is the average concentration of hemoglobin in a given red cell volume. So the normal value is 32 to 36 gram per deciliter. Now comes to the management of the anemia. Care objective. Firstly, there will be determining the cause of the anemia. Etiology is often multifactorial. Even when there is an obvious cause, investigation of serious underlying causes like the cancer in adults is recommended. So aim of treatment is normalize hemoglobin level and red cell indices, replenish the iron store, individualize the disease specific management depending on underlying cause. And lifestyle management, it is recommended that patient with the iron deficiency receives the dietary advice. Non-pharmacological management is that tea and coffee inhibits iron absorption when consumed with the meal or shortly after the meal. Vitamin C is also a powerful enhancer of iron absorption from non-meat food when consumed with the meal. The size of vitamin C effects on the iron absorption increases with the quantity of vitamin C in the meal. And germination and fermentation of cereal and legumes improve the bioavailability of iron by reducing the content of phytate, a substance in the food that inhibits iron absorption. Promote and support exclusive breastfeeding for about 6 months, followed by breastfeeding and appropriate complementary food, including the iron rich through the second year of life, will decrease the chances of iron deficiency anemia in the child. So this is the recommended dietary allowance of the iron uh, per day in the adult man. It daily iron requirement is 8 mg in the woman, adult woman, 8 mg in the adult with the age of 19 to 50. 18 mg iron per day is required in the pregnant woman. 27 mg iron per day is required in the lactating woman. It's 9 mg to 10 mg iron per day is required. Adolescent in the girls it's 8 to 15 mg, and in the boys is 8 to 11 mg iron per day is required. Children's birth to the age of 8 or age 4 to 8, 10 mg is required, and in the infants from the 7th month to the age of 1 year, 11 mg is required, and from birth to 6 months only 0.27 mg is required. Management. There is a complementary parasite control management can be given. Anti-helminthic therapy with the 400 mg of single dose of albendazole can be given to eliminate hookworm before the initiation of iron and folic acid therapy in the children with the age of less than 2 years. 200 mg per day single dose of albendazole can be given. Remember that albendazole is contraindicated in the first trimester in pregnant women, but can be given in the second and third trimester. Now, the treatment of anemia between the age of 6 to 24 months, the dosage is 12.5 mg of iron plus 50 microgram of folic acid daily, and duration is from 6 to 24 months of age. And now the treatment of mild and moderate anemia in the different age groups. In the age group of children 2 to 5 years, 30 to 20 to 30 mg iron per day is required. In the children 6 to 11 year, 30 to 60 mg iron is required. In adult and adolescents, 60 mg per day is required to treat the mild or moderate anemia. And anemia will correct within 2 to 4 months, but if proper dose of iron is given and cause of iron deficiency is corrected, then continue iron therapy an additional 4 to 6 months in adults after the hemoglobin becomes normal to replenish the iron store. So in this table, we can see the treatment of severe anemia in the different age groups. In if a patient is less than of 2 year, 25 mg of iron plus 100 to 400 microgram of folic acid uh, daily is recommended for the duration of 3 months. Age group from 2 to 12 years, 60 mg iron plus 400 microgram of folic acid daily is recommended for the age of for the duration of 3 months. And in adolescent and adults, including pregnant women, 120 microgram of iron plus 400 uh, microgram of folic acid daily recommended for the duration of 3 months. After completing the 3 months of therapeutic supplementation, the pregnant woman and infant should continue the preventive program of iron supplementation. In the pregnant woman, the dosage of the iron intake will be 60 mg iron plus 400 microgram folic acid daily, 6 months in the pregnancy, and continue to 3 months postpartum. So iron absorption may be decreased by the antacids or supplements containing aluminium, magnesium, calcium, zinc, proton pump inhibitor. Space administration apart by at least 2 hours. Oral iron preparation may cause nausea, vomiting, dyspepsia, constipation, diarrhea, or dog stool. Strategies to minimize these effects include at a lower dose and start at a lower dose and then increase gradually over 4 to 5 days, giving divided dose or the lowest effective dose or taking supplement with the meal. And although sustained release iron preparation tends toward less GI side effects, that they may not be as effective as standard film coated products due to reduced iron absorption. So this is data of the Pakistan anemia in the children under the age of 5. Severe deficiency is seen in 5.7%, and moderate deficiency is seen in 48% of the population. And 2001 severe anemia was 50.9, but in 2018 severe anemia occurs 53.7%. Anemia among the adolescent girls in Pakistan, more than half, which is 54.7% of the adolescent girls in Pakistan are anemic, and adolescent girls in the rural area are more likely, which is 56.0% to be anemic than the counterpart in the urban area. Anemia among the women of reproductive age, severe anemia is occurred in 1%, and moderate anemia occurs in 41.7%. And about 41.7% of women of reproductive age are anemic, with slightly higher proportion in the rural area, which is 44.3%, than the urban setting, which is 40.2%. Now it's time for the recent updates. The influence of nutritional supplementation of iron deficiency anemia on pregnancies associated with the SARS-CoV-2 infection. This article was published in 2022, and this research occurred in the Romania. In this research, researchers said that anemia is a very common occurrence during pregnancy, with important variation during each trimester. Anemia was also considered a risk factor for severity and negative outcome in patients with the SARS-CoV-2 infection. So we developed a study to determine the impact of nutritional supplementation for the iron deficiency anemia in correlation with the status SARS-CoV-2 infection. So in this study, a total of 95 pregnant women were diagnosed with the COVID-19, having significantly higher proportion of iron deficiency anemia. They were having low birth weight, prematurity, and low APGAR score was statistically more occurring in the COVID-19 births. So birth weight showed a wide variation by nutritional supplementation during pregnancy. A daily combination of iron and folate was the optimal choice to normalize the birth weight at the But so it is recommended to the supplement the nutritional intake of 2 hour to promote the normal development and growth of newborn and avoid multiple complications during pregnancy in the SARS in the COVID-19 pandemic setting. So it's time for the MCQs now. MCQ number one. A researcher wants to do a study regarding the anemia in the child under the age of 5. His supervisor told him to take the sample by considering the global prevalence. So, what is the global prevalence of anemia in the children less than 5 years of age? Option A is 38%, option B is 39%, option C is 40%, option D is 41%, and option E is 42%. What could be the answer? Anyone?
Charlie?
Answer here is 42%. E is the right answer. Question number
Okay.
two. A boy of 10 years of age admitted for an operation with the HB level of 10.5. In the theater, there was a conflict between the surgeon and the anesthetist regarding the HB level of the patient. According to anesthetist, patient is anemic, but according to surgeon, he is not. What should be the minimum value of HB for a 10-year-old boy? A is 10.5, B is 9.5 gram per deciliter, C is 11.5 gram per
Beta,
deciliter, D is 12.5 gram per deciliter, and E is 13 gram per deciliter.
beta,
Delta?
Sorry?
C,
Yes, C is the
Delta?
right answer, 11.5 gram per deciliter. Question number three. A 30-year-old patient presented in the OPD. Patient was diagnosed as a gastric ulcer 1 year back and remained untreated. In CBC, HB was 9, MCHC was normal, but MCV was high. So, what can be the diagnosis of that patient? A is aplastic anemia, B is pernicious anemia, C is iron
B,
deficiency. Yes,
Beta?
B is the right answer, pernicious anemia. Question number four. A 21-year-old boy fainted in his college class. Upon taking to the emergency, his father gave history of not taking any kind of meat from the last 8 years. His CBC shows HB level was 4 gram per deciliter, MCV and MCHC was lower than the normal value, and but all the other cell line was normal. What will be the top differential diagnosis for this patient? Iron deficiency anemia, megaloblastic anemia, hemolytic anemia, aplastic anemia, or folate deficiency anemia.
B.
alpha,
Yes, alpha is the right answer. Iron deficiency anemia. Question number five. A female patient of 63-year-old went to doctor and was concerned about her health. In history, she said that she takes 12 cups of tea and has depression. What will be the level of risk of having anemia in this patient? Low risk of anemia, high risk of anemia, very low risk of anemia, no risk of anemia, or very high risk of anemia.
Beta?
E is the right answer. Very high risk of anemia. In this patient, three different kind of risk factor, which is the female and elderly, and intake of tea, or 12 cups of tea, and depression. So all of these factors combines and put the patient in a very high risk of anemia. Question number C. Uh, a 50-year-old patient presented in the OPD to a pulmonologist. He complained of having shortness of breath. Chest was clear on examination. He was having history of diabetes, hypertension, and ischemic heart disease. HP level is 10 gram per deciliter. What is the most probable cause of shortness of breath in this case?
Delta?
Yes, delta is the
C,
right answer. As the chest is clear, so delta will be the right answer, anemia. Question number 7. A patient presented in the mother care center. She was breastfeeding her 5 months old child. She was concerned about the macronutrient intake in the diet. What will be the daily iron requirement for this mother? A is 6 to 8 mg per day. B is 9 to 10 mg per day. C is 18 mg per day. D is 27 mg per day. E is 14 to 15 mg per day.
D.
D.
It's beta 9 to 10 gram mg of iron per day will be the requirement for the lactating mothers. Question number 8. A 45-year-old patient presented in the OPD with a complaint of early fatigue. He was diagnosed as iron deficiency anemia. Anemia was corrected after 4 to 5 months of iron intake. For how much more months iron is required to replenish the iron stores? Option A is 2 to 3 months. Option B is 4 to 6 months. Option C is 5 to 6 months. Option D is 1 to 2 months. Or option E is 7 to 8 months.
4 to 6 months.
Yes, B is the right answer, 4 to 6 months. A 11-year-old female presented in the emergency was diagnosed as a severe form of iron deficiency anemia. What is the amount of iron and other supplements should be given to the patient as a therapeutic management of severe anemia in 11-year-old child? Uh, Option A is 60 mg iron with 400 microgram of folate for 3 months. 60 mg iron with 400 microgram of folate for 10 months. 70 mg iron and 300 microgram folate for 8 months. And D is 100 mg iron and 60 mg folate. And option E is 98 mg of iron and 78 mg of folate.
It's B.
Alpha is the
Beta.
right answer. 60 mg iron and 400 microgram of folate for 3 months. Question number 10. In 2021, 40 COVID affected pregnant ladies gave birth to the low birth weight child. After doing research, it was observed that lack of specific nutrient causes this low birth child. So, what is that nutrient which leads to the low birth weight child in COVID affected pregnant ladies?
Charlie.
C.
C is the right answer. Iron.
Charlie.
This is the key, and this is the YouTube link for this presentation. And thank you.
Thank you very much for your advances, recent advances, and all the things that you examples that you have given are wonderfully placed. Another important thing is that your MCQs all are 5 optioned MCQs, and scenarios were also given, and that is again one of the thing that is commendable. We would also discuss another thing. Would you please stop the recording so that we can discuss it freely?